So this is for PNs and for RNs because, I teach both courses and they're both the same information. It's what you do with that information. Do you tell somebody to do it or can you do it yourself? RN, PN, you're both taught almost the same type of information. Okay. So that's why I say it's all pediatrics. Everybody's here. Again, anybody, any questions, you're not getting what I'm talking about. I want you to stop me and I want you to say, I don't get that. Could you please describe it a little bit more? And I can always find another way to describe it. You're lucky my daughter's taught me how to be very descriptive when I discuss things, or else I'm going to have to tell her 3 times until she gets it. So I don't mind. So here we go. And UR 203, but I said it's PNR 204. It's the HESI review. So we're going to start with infants and nutrition development and go into body systems and how to think now. So you've been given all this information. So nutrition, we know nutrition, nutrition, nutrition. Without it, they're not going to be cognitively aware as infants and even young children, and they're not going to grow. Okay. What about IBS, older children and younger ones? That's something where they're spitting up, right? They are losing it with diarrhea or they're not eating, they're not getting nutrition. What's going to happen? Well, again, that is those developmental delays, cognitive delays. That is, they're not going to meet those milestones because they don't have fuel for the tank, right? So remember, you're not getting nutrition. How do you measure it? Those things. GERD, gastroesophageal reflux in children. Again, what is going on with infants with reflux? They're losing nutrition every time they have a spit up, aren't they? And when they're losing that nutrition, what's going to happen? They're not going to be getting everything that they need, and they're not going to be growing. Okay, hold on. Now, foods that heal osteomyelitis. Well, this is when you're talking about what you need for an infection, what you could need for strong bones. This is one of those globals. What can I feed my child to help them if they have osteomyelitis? Because usually that's at least a month or more of IV antibiotics. So you need fruits, vegetables, whole grain breads, low fat dairy products, beans, meats, fish. You see, there's a lot of protein there. Okay. And that helps with healing. Anything with nutrition, any age child under overweight, we want to know some sort of history. Is it like, what did they eat for breakfast? What did they eat yesterday? Or then maybe a 3-day history. And then are they children that are overweight? What sort of physical activity do they have? Do they have PE in school? Are they active in it? These are questions with nutrition that can help us make a plan and determine why they're overweight or even underweight. Celiac disease. Now, you have a child in the hospital, an adult, doesn't matter, any patient with celiac disease. You're bringing the tray in for them to eat, and on it you see soup with a package of crackers. What would you do? I'm going to take those crackers off because maybe they forget and eat it, and now you have a child in severe abdominal pain because they had gluten. Remember, wheat, raw rye, barley, oats, they can't have it. And if they eat it, they're bent over in pain. So remember, any sort of special diet, and we're seeing something's not right on the tray, take it off. That's what we do, our job. Now, sometimes infants get this white patch on their tongue called ungo for the Espanol people. That's me being in Miami and what I've heard for my career down here with the parents. How do we treat it? Well, you can't scrape it off with a tongue blade. No, it won't go away. And actually, that will hurt because it is actually a little bit painful. They need to get nystatin. And how do we give nystatin? Well, not in a nipple, not in a syringe. We take and make a swab of a Q-tip and swab it on the areas that are white patches. Now, nutrition, diaper rashes, they go hand in hand, probably due to some either dermatitis or even foods that are coming up. So you get this infant, they're telling you they're not sleeping. Well, before you start ruling out things like diet and milk and those things, look at comfort first. The simple, the assessment. Do they have a diaper rash? If they have a diaper rash, as soon as they urinate, they are going to cry because it burns, or if they stool, right? So again, let's think about not just only the other things that we've been taught about, but just remember that assessment. It could be as simple as diaper rash. Remember, introducing foods is around 5, 6 months old, and it's one at a time, 4 to 7 day intervals. And we know rice cereal is the least allergenic to start. Now let's start with development. Let's talk about some infants and let's talk about little things we've talked about and things that are important for your little infants. Remember, infants are ages 0 to age 1. One of the things I worked many, many years in a cardiac ICU and a newborn ICU, and every beginning of shift, you do a head circumference, an abdominal circumference, and a chest circumference. We're looking at for something. So why am I measuring the head? Well, we're seeing and making sure it's not getting bigger. We can't predict when a child is having hydrocephalus that doesn't have like a myelomeningocele or something else going on. But a normal, healthy, born baby can all of a sudden get a big head, and we know that could be that fluid building in there. What else are we going to be looking at? Head's getting bigger. That fontanelle is going to start getting big and it's going to get full. It's not going to sink. Extra fluid is in there. The head's getting bigger. It's going to start looking big and tempting. Always remember, young children, infants, self-soothing is a pacifier. And it's part of their normal growth and development, that everything in the mouth, right? Explore the world through their mouth, soothe themselves through the mouth. So, for instance, you have a child with a TE fistula who is NPO, cannot eat, because everything they eat goes into their lungs. So, what would you make sure that child has for normal growth? We're going to be giving them that pacifier. And that pacifier is going to give them that ability to suck. It's going to satisfy their need. Yes, they'll get hyperal or whatever for feeding, but at least they got that sucking going on. Many times you see parents comparing the older brother and the younger sister, and they're different. Well, all children are different. Just find out why are they saying they're different? Is it that they're 8 months old and they can't lift their head? Or they 8 months old and they've just started to sit, but they're not unsupported quite yet? There's a difference. An 8-month-old should sit unsupported, but if they're almost there, it's normal. And always say, everyone is different. Remember, any infant, failure to thrive, skinny infants, or even could be due to GERD, or could be due to cardiac, tiring out, heart failure. Any of those children who have to work hard to eat, or, we know that they are underweight, we can increase calories in breast milk, and we can increase it also in the formulas. So normal formula is 20 calories per ounce. We could go up to 30 calories per ounce. So you get 1.5 the amount of calories and the same thing. So they're not sucking as long. And again, you're saving the energy, therefore they're not burning the calories too. Toddlers. These are me, mine, and these are children who want to do it all themselves, right? And we need to let them do. Now, when we're talking to a toddler and preparing to teach them about something, number one, you have to get on their level physically. You never tower over them. And then you're going to explain on their level of understanding, their level of development. You got to break open the ice. I play all the time with my toddlers. And playing made it fun and made the child less threatened, and they could learn because they didn't put barriers up, because I didn't scare them. Okay. So get on their level. Preschoolers, so ages 3, these children should be speaking at least 4 or more word sentences. That's the minimum right there. So they're getting older, 3 to 5. Autism. Autism, we know it's those repetitive behaviors. They do something over and over and over again. I saw this one little boy where I was doing pediatric clinicals. He took a fire truck and put it on a stool, and took a doll and put it on top of the fire truck. And then he took another little something and put it on top. And then he put a blanket on top, sat back and looked, took the blanket off, took the toy off, took the doll off, took the truck off. Repeat, fire truck back up. And I'm telling you 10 times, over and over. They find this soothing. They know what's coming next. Now, there are questionnaires, just know it. This is one of the ones that can diagnose autism. It's a questionnaire to be done. It's just to let you know that they're there. School age children. Well, school age children are the ones that like to do things for themselves, and they like what they're good at, right? This is their industry. I feel good at what I'm doing and I do it well. The inferiority is, I'm not good at math at all. And it makes me feel really inferior or bad, right? All right. Now we're talking about growth in school age children. By this time, school age children, are getting taller. And then it comes into, well, you have a shorter child. Do we put them on growth hormones, right? If their percentages, they're low, it could be an option. But what's the most important thing to ask before we do anything like that? If all your family are 5 foot tall, you're not going to be 6 foot, no matter how much growth hormone I give you, right? So if mom and dad are all short, aunts, uncles, it's not going to get taller than that. So this is one of the big questions to ask. What about your brother and sister who are not there when you're in the hospital? Those children are also getting really nervous. They're also upset because mom and dad are spending all their time at the hospital, right? So remembering siblings. I've done many different things for them. I've sent home crayons and coloring books about the hospital that we have there. I've sent home ribbons that I make for the girls, for their sisters. Had them sit there and take a paper and put stickers on them, send them home to their siblings. This is part of the kid in the hospital still connecting with their brother and sister at home. We're lucky today we have Facebook, but those things in hand, the touch, really make it even better. Going into surgery or being admitted into a hospital, what are some things that are important to understand? Have they been there before, and how did they respond to it? You have some children go in, they went in for a MRI and they just laid there and everything was lovely. Then you'll have the kid who screamed and yelled and, ran out into the parking lot because they didn't want you to touch them. So you have both sort of things. So what was their reaction to the other hospitalizations? Let's prevent them from running out, into the parking lot. Let's have them well prepared, right? Where we get on their level and do teaching for them to understand. Some children need more attention than others and getting them ready. So, adolescence. When we have an adolescent who's in the hospital over and over again, let's say it's a cystic fibrosis or the congenital heart disease, they're in and out of hospitals all the time. These children feel really secluded from normal type events. If there's other adolescents in the hospital that they fit, with the child, that means you can't have somebody with an infection in with a child who's cystic fibrosis because they're going to get it. But if it's diabetes and a cystic fibrosis, there's no infection to be given. They can let them be with those adolescents. It helps them talk about the way they're feeling, right? And we need to remember these things. Tanner stages of development. There's been questions on Tanners and they want the stage number. So how do you remember that? What happens at first to a girl? It's stage 2 now. It's a breast bud. You start seeing little breasts, right? And then what happens with males? And that's the enlargement of the scrotum or testes. I mean, most moms don't know that, but if you ask a boy, they'll tell you those things. And then at 5, it's your mature. So 2, 3, 4, 5, you can sort of figure out, are they with breast buds? Are they full breasts? You know, what's going on now. Another thing about adolescents is, you know, they're more sexually active than ever. I mean, it's just part of the hormones, right? And you get a girl, even males coming in, they want to know about some sort of contraceptive. I mean, girls would be oral contraceptives, males would probably want the condoms, whatever. But can you talk to them? This is a 15-year-old, 16-year-old. Can you talk to them? You don't have to tell mom, but you can't put your opinion. Only what is a valid research. Benefits, risk, written, oral, not your opinion. You should say you shouldn't mess with that, but you know, adolescents going to do what they want. So give them their information. So here we are, Piaget. Piaget is all about thinking, right? So Piaget starts out with, all right, I got this rattle in my hand. I moved it. Oh, it made a noise. I like it. So they have figured out something else. Remember, they don't know how to think when they're born. They can just suck, swallow, and breathe. That's all they do at birth. And then as they grow, they're starting to take that rattle and now putting it in the mouth because it tastes good. And I like chewing on it because my teeth are coming up, right? So one of the things that we call Piaget is object permanence. You take a toy, put it behind or under a blankie. That child is on tummy time. They're going to wiggle and woggle and they're going to pull the blanket and they're going to find that toy. Even though it's hidden, it's still there and they know that now. Erickson, the most tested of all of your theorists. Remember, infant is trust and mistrust. That's all about when I cry, I know somebody's coming to get me and all my needs are met. And I'm a happy, healthy baby. Remember, the nobody comes to get me when I cry is mistrust. And they're unhappy children, really unhappy children. Then it goes to school age, the most tested. School age is all about industry. My house, my factory, what I have built and made, and I do that really well. All right. When you are giving a school age children, let's say they are in a hospital and they're there for 2 months and we know they're going to be, we need to give them things that will challenge them, you know, to occupy time, to distract them from all the medical stuff, right? Never give it over their head. Don't give them something that they cannot accomplish because that goes into inferiority. For instance, I use this puzzle all the time. A 6-year-old, you're not going to give them a 1,000-piece puzzle of the ocean, which is all blues. I mean, come on. That 6-year-old is going to go bonkers and is going to throw it and it's going to be the end. That wouldn't be a good thing. Now, maybe a 50, 100, you know, thing of a house or a picture of an animal, a dog, where there's different colors and it's easier, but still difficult to put together. So challenge them, but don't frustrate them. Adolescence, all about me. Who am I? What am I going to be when I grow up? It's like all of a sudden now you've got to act like a grown up and figure out when I become an adult, what am I going to be to take care of myself? Do I like girls? Do I like boys? What group do I hang with? Is it the band? Is it the sports? Is it the arts? Is it drama? Is it the government? Which one? All of this stuff, identity, big frustration. And then I'm too skinny, I'm too fat, my hair's too curly, it's too straight, too many pimples, body image, the clothes you wear, etc. All very important to an adolescent. And remember, with adolescent, if you need to ask them information that could be uncomfortable for that teenager and they're not going to talk to you in front of their parents, have the parent leave the room. And you do not have to tell the parent what they said, unless it's something that's going to harm themselves or others. All right, let's run down some body systems here and ways of thinking of things that, wasn't completely said in class, but, was mentioned. We talked what hemophilia is. It's bleeding, it's factors, it's what do we do? You have a child with hemophilia, and some you don't diagnose till later on. Sometimes you do at birth, but sometimes it's later on in life that we see the diagnosis. Maybe they're one or two. What are toddlers doing at that age? They're running around, they're waddling, walking, falling down, running into things. So again, you can't stop them from running. I mean, that's an impossibility, but you can make the furniture, pad the edges, keep the sharp stuff away, any sharp corners take care of, anything that's there that could them get rid of it, or put it way up, they can't touch it or lock it away. If a child is having bleeding, fell down, we know that first thing to do, it's just like a sprain. We're going to tell them stop, put ice on it. We're going to put a ACE bandage on it and elevate. So rest, ice, contain, elevate. Going to try to stop that bleeding from occur. Did you all get the NCLEX questions on nosebleeds intervention? It's always one that I've seen almost every quarter. Nosebleed, what do you do? Well, number one, calm the child down. Remember, most kids think that they're bleeding, they're going to bleed to death, they're going to die. So they're running around screaming and yelling, and their blood everywhere. Heart rate's up, and all they're doing is bleeding more. First thing, calm the child down. Thumb and forefinger on the soft bridge of the nose and hold it snugly 10 minutes. If after 10 minutes it's still bleeding, they need to seek medical attention. That is nosebleed intervention. And you do not put their heads back. You put them forward. If you put it back, they're going to swallow it. And then guess what's going to happen? It's going to make their stomach sick and they're going to vomit it and re-injure that nose and start the bleeding all over again. So lean them forward, pinch the nose, 10 minutes. Part of hematology and bleeding and coagulopathies that we see is when your platelets are low. Now, platelets could be low due to a viral infection, could be due to any of the diagnoses, ALL, AML, any of those things. But remember, if a child's platelets is low and they're in the hospital with you, these children are at risk for bleeding. These children will go on bleeding precautions. Soft toothbrush. We're going to no IM injections, and if all possible, right? These children be monitoring bruising and petechiae and blood in the urine or blood in the stool, et cetera, et cetera. And then, of course, we'll be monitoring the CBC because usually we'll take one every morning to look at it. Sickle cell disease, the biggest treatment, home care, hydration, hydration, hydration. Sickle cell disease is all about blood can't get through the vessels and they get stuck because they're too tiny. How do you make a vessel bigger? Put more volume in there. How do you put more volume? Drink, 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 drink. And if you're in the cold, make sure that they are dressed appropriately. Make sure they have, hats and mittens and boots and warm clothing, because again, cold will constrict and cause a sickle cell crisis. They also say with sickle cell, if you're going in an airplane, because of the pressure and the cabin pressure, have hydration before getting on planes. ALL, or any immunosuppressive type of diagnosis, the whole priority is always prevent infections. And ALL in particular, in a private room, you don't want to give any other germs to that child. What would be a priority problem that you would tell the doctor about with a child, ALL, or an immunosuppressed child? Fever. They have a fever, you better be concerned. There is no immune system. They are immunosuppressed. They need treatment now, or they're going to go into septic shock. Somebody check their mute button, please. Somebody's giggling. Hold on, let me find it.
Steve? Wait, Steve.
I think I got them all now. All right, thank you for waiting for that one. All right, iron deficient anemia. Remember, iron, if it's that liquid, through a straw so that it doesn't stain the teeth. Remember, iron is digested and made ready for the body by the stomach acids. And if we take it with orange juice, it speeds up that being released into the body. JIA. When you have a child with JIA, there's so many things that can go on with them, right? What's the big thing with JIA and orthopedics? Remember, juvenile idiopathic arthritis or juvenile rheumatoid arthritis. They're both used PN and RN classes. It's where your joints are swollen. One of the big things is to keep them moving. Swimming is a great exercise for this because it doesn't jostle the joints, okay? With children, they have to follow a plan. Let's say they have to make sure that they, get up and they do their exercise and they have to take their medicine, or they go to school and they're doing everything right. School-age children still need to get a reward from being compliant about it. And younger school-age children, are going to need instructions made so they can follow them. Usually instruction boards they check off. Be great. As they get older, they won't. You have a child fell off a monkey bars, arms went down, and they're complaining of pain. What is your biggest concern? Kid comes in holding their arm and you can see it swollen at the wrist and it's really painful and they're holding it and they're crying. First thing, I'm going to check those fingers for capillary refill. I'm going to check their pulse for a radial pulse, right? It's all about neurovascular signs. That's your biggest thing. And then after that, putting a splint on it, making it more comfortable to get the x-ray done and the cast, etc. As I said, JIA physical therapy is great, but as I said, swimming pool is just as good if they're not going to do stretching exercises like that, or with a physical therapy person. Now, children with scoliosis, with a greater than 55 or 50% curvature, are going to be needing some sort of spinal surgery because that curve is pushing on one of the lungs and not letting it expand. So it's all about airway. So they've got to straighten it out the best they can. And they'll either do spinal fusion or Harrington rods. But the thing is, post-operatively, this is the child that needs to be log rolled, putting something between their legs, holding them, two people at least doing it, turning them as one, a log roll, because we don't want to move that spine and then undo what the surgery just did. Osteomyelitis, important information. Remember all of those fruits and vegetables and whole grain stuff. That's what we're going to feed them when they have it. But also, one of the questions, if you have a child with osteo, is this child getting frequent infections? Is something else going on that needs to be looked at? Cardiac, you're my favorite subject, right? I know it's difficult for you all. Kawasaki, what is it? It is biggest concern about little microemboluses because of this vascularitis. And our priority is to give IVIG, and we're going to be given aspirin, high dose aspirin. Well, why aspirin? Well, the aspirin is given for anti-inflammatory. It's also given to thin the blood and prevent clots. And what is that priority procedure and what does that mean? Well, the biggest concern with Kawasaki is that they have these blowouts, these aneurysms in the coronary arteries. And if it's already gotten to that point, if it blows, you're going to have a myocardial infarction and it's not a good outcome. So once we determine Kawasaki, we're doing an echocardiogram to look at it.
Professor Borga, I have a question.
Sure.
Do you worry about Rye disease when giving aspirin with the Kawasaki?
No, benefits outweighing risks. Now, if there is some sort of metabolic condition that we know about before this, we can always give Coumadin. But
Okay, thank
most
you.
of the time, most of the books, they say aspirin, okay? But that was a great question. Absolutely. If they know, but usually they'll just go directly to aspirin. It seems actually with what we know, Ray's disease and all that stuff, it's actually more benign to get that blood thin right away. Prostaglandins, this is what mommy secretes when the baby's intrautero, and it's all your fetal circulation. When the baby is born, that prostaglandin stops, usually because mom's gone, and that PDA closes within, they say, 3 weeks. Well, sometimes we need to keep it open because it's the only way to get the oxygen from the lungs to the body. The big side effect of prostaglandins, even an extremely slow, continuous infusion, is bradycardia. The other one is actually hyperthermia. So those are two things to look for. Now, when that PDA doesn't close, and we don't need it, we can close it, and we can close it medically. All right. So we can close it giving 3 doses indomethacin. And I loved giving indomethacin with a child with a PDA because I would be listening to the murmur, and you could watch it as that was being infused. I would do it every 6 hours, listen. And it would be a decrease and a decrease. So we know it is working because the murmur's decreasing. So you have congenital heart disease. They don't look good. They're gained weight. What do you think is going on? Congenital heart disease and weight gain equals congestive failure. The lungs are filling up. When you see congenital heart, weight gain, think of heart failure. They can't get the blood to the kidneys and get rid of the urine. So if you saw that weight gain and they weren't looking good, what are you going to do? Listen to breath sounds. As simple as that. Cardiac catheterization, we know postoperatively it's checking that dressing. And our biggest risk is checking for bleeding. Think about the femoral artery and the femoral vein, both had catheters put into it. So if it starts bleeding, these children will bleed a lot and real quick. Take 2 fingers, put it above the site, closer to the heart, push down, and then you call for help. And they'll evaluate, call the doctor, how much they bled, and what interventions will be done. Usually nothing, just reapply the Band-Aid, unless it's a lot, and then of course we're gonna need blood. Digoxin. Now, digoxin is used in neonates, infants, very safely. And what do we do? How do we give it? Well, there's no difference between adults and neonate in what we do. We're going to count a heart rate. Well, that's why you have to know those heart rates, right? Something that I would look at. What's the potassium level? If it's too low, you're not going to give it. Is the digoxin level too high? All right, so these are things. Now, sometimes you'll have an infant that is vomiting. Heart rate's a little low. This could be, if they're on digoxin, digitoxicity. It's not too bad. Just hold the dose, call the doctor, get a level. It's the safest thing for that to be done. Rheumatic fever. You have a kid comes in rheumatic fever. It's a bacterial infection. We know it's strep. We're going to be treating it with antibiotics. Also with that, part of rheumatic fever is that chorea, those weird movements. It's that joints that are swollen, the rash. All of that goes away. The only thing that cannot be corrected with the antibiotic because of rheumatic fever due to strep is a heart valve damage. Once it's damaged, and it's the mitral valve, once it's damaged, it's damaged. And you're going to have to treat it medically, surgically, whatever. The urinary system, UTI, one of the big things to diagnose it and say that it is a lot of times is just to say, oh, my kid urinated the bed last night for the first time. Something's going on. And then check, because kids don't wet beds unless something's happening, okay? Cryptorchidism, testicles are not in the testicle sac, right? How do you examine them? Well, you're not going to do cold because it's going to pull them inwards. Warm room will let them hang. And if you can feel them, you can. If you can't, one of the questions to ask that parent, the mother, father, whoever, is have you seen it before? Because usually you've got about a year to get them down, give or take a couple months. But the question is, have you seen the testicles before? Remember things like long-term antibiotics. Think about osteomyelitis. It's usually due to staph infection. You need IV antibiotics. What's the one IV antibiotic used for staph? The big guns, as we call it. That's vancomycin. What's the problem with vancomycin and how to administer it? Peaks and troughs. And if we don't monitor that, what can happen? Hearing loss. And we also can cause kidney damage. So what are we going to be watching? Is the child still hearing okay? And is the urine output good? Because remember, those drugs are really hard on the body. We need to know what to look for and to teach those parents. Nephrotic syndrome. This is when all the proteins urinated out. Nothing to do with kidney failure. You're still urinating. It's not a problem. But one of the ways that we can get some of the fluid out of the tissue is replacing protein in the blood vessels, right? So we give something called albumin. Now, albumin is protein. So you put the protein back in, it pulls the fluid back in the vessels, goes through the kidneys, and you're going to see urine output's going to increase, and you're going to see the edema decreasing. Did you hear that concept? No protein, you give it back in the vessel, it sucks the fluid back out of the tissue through the kidneys, and you know it's working because the edema is going away. Now, hypospadias, epispadias, it's where the urethra is not at the tip of the penis. It's either hypospadias underneath or epispadias is up on top. We know that these children, no matter religious background, they cannot have a circumcision. We need that tissue for the plastic closure. If you see that picture, they fillet the whole penis open. They make a canal. They put in a catheter that will stay there for 7 to 10 days. We don't touch that catheter, but we make sure that the tip of it's in a diaper or urine will be everywhere. And if this kid is a toddler, and we like to do it usually before potty training. That's usually our goal with anything with their genitals before they're potty trained, because they're all into this castration and all that, right? So some of them are young toddlers. This kid, you're not going to let them be on a riding horse and bouncing on it. You need to protect the penis. No big heavy balls throwing. Doing something quietly which they're not doing anything that could hit or harm their penis. Okay. So that is hypospadias, epispadias. Wilms tumor, kidney tumor. Don't touch it. Do not palpate. And the other thing is, this is a tumor that most we go to see what it is before surgery, right? We don't touch this one. And it's the same reason as no touching, no palpating abdomen. Putting a hole into that tumor to get a piece out for biopsy has left an area where little bits metastasize in the peritoneal cavity. So no pre-op biopsy on this child. Chronic kidney disease. One of the big things is all about osteodystrophy and vitamin D. Also has to do with calcium, erythropoietin, all the things that chronic kidney disease, the issues that they do have. Remember, osteodystrophy is you could have slow growth, you could have crooked bones coming on, and they do need erythropoietin, calcium, and vitamin D in their diet, and it can help. Remember glomerulonephritis? Don't assume that all of them are strep. Some of them happen due to other reasons. So if you have glomerulonephritis, the first thing I am going to check, have they had a strep infection? Remember that ASO titer? It's an anti-streptolysin titer, strep in the middle. It tells you if there was strep on that child. And then how would we treat the glomerulonephritis? Not just what we're seeing, but giving them that antibiotic, okay? Testicular pain is an emergency. Could be torsion, could be a little bit of anything. Should be telling that to the doctor as soon as we can. Respiratory, epiglottitis. Well, epiglottitis, let's go to just croup first. Croup is all upper airway, oropharyngeal. It is where it gets swollen. And what happens is these children have a hard time breathing air in, right? Because it's all upper. Can't go in, but comes out okay. And the croup is that big bark thing. Well, it can swell to the point where it could turn into epiglottitis. Okay. Also, croup that's been treated in the hospital, they've given you some sort of racemic epi aerosol or steroid, and the parents now calling you or coming back, they can't swallow secretions. Guess what? This is now epiglottitis. This is a true and real emergency. This child needs to get back, and seek care right away. It wouldn't be something that we would just, say, okay, well, they're not swallowing, that's normal. No, it's not. You are now into a very critical place. So epiglottitis, what do you see? That's croup that has gone on, to the worst degree that it can go. Swelling, the epiglottis is covering the trachea, air can't go in. So what equipment is needed to the bedside? Well, airway. We're going to be needing to have a tracheostomy tray. We're going to need an intubation tray. And what would we see? Well, you would barely hear air going in. Maybe if you're lucky. Children bent over tripod, like old ladies with COPD, right? And then drooling, they can't swallow. So that's from the croup thing that was going on, right? And if they talk, it's all garbled. So these children, get them calm, get them, their IVs in, get their racemic epis, give them all their steroids, et cetera. But always be prepared for the worst with the trach tray and the endotracheal intubation tray. Now, RSV is a common cold for you or me. Young infants, though, remember I said they barely suck, swallow, and breathe at birth. That's all they know. Cognitively, they learn it when you put the bottle in their mouth. They didn't know about it before, usually, unless they stuck their finger into utero, but they don't know anything. So RSV is all about mucus. in their nose and they can't breathe well. Now, it's okay for normal, healthy children, but what about a child with congenital heart disease or cystic fibrosis or some sort of immunosuppressive disease? Well, we don't want them to overwork their body. Premature children are in the class who would get this also. So these children would be from winter to early spring, get monthly vaccines for the first year only. So is that 6, 7 months of it? Every month they will be getting it. Also, children with RSV should be placed in their own room until we determine exactly what's going on with it. Because this is upper airway, this is fever, we don't know all what's happening. So placement be very important, and also to rule out pertussis, et cetera, et cetera. What is their immunization status? Have you had your immunizations yet? It really helps with the placement. Remember infants when they're in respiratory distress. Yes, they're going to have all of the retractions and all of that stuff, but they get the flaring, nasal flaring, and that that's the grunt at the end of every breath. If you have a child in respiratory distress, they're nasal flaring, grunting, and retracting, and head bobbing. This child is going to require some assistance really quickly. This is where I say, hello, doc, you need to come here now. Cystic fibrosis is twofold. It's the lungs, where we treat with aggressive chest physiotherapy. And we treat the nutritional part with it's a pancreas insufficiency. And we're going to be giving them enzymes before meals. Okay. And remember, these enzymes never break up the little balls of it. Powder can be sprinkled. Please rinse your mouth after powder. And remember, children grow. Make sure their doses gets more as they go on. And then let's say we didn't know a kid's going to have CF. They don't have a CF meconium stool, right? Which means no stool at birth. We don't know anything. And a mother kisses the baby and says that baby tastes salty. Well, we're going to do that sweat chloride test. And most likely, if she's tasting salt, this child is cystic fibrosis. And albuterol, we know it's our rescue. You can't breathe. Number one, albuterol is the way to use it. So here we go now with GI. So diarrhea, we know we're losing a lot of alkaline. You're left with metabolic acidosis. With that alkaline coming out, check their buttocks for all the breakdown. You get a child in with having really bad diarrhea, we're going to rehydrate them, whether orally or IV or both, but also make sure you check that assessment. Many times we don't. Have a child in abdominal pain. What do we need to know? Well, where is it? Is it on their umbilicus? Is it, heartburn right under their xiphoid process? Or is it a right lower quadrant? Makes a difference in how we treat them, doesn't it? How about a child who, and I want to give you that status post-abdominal surgery for Wilms tumor. They got to go right through the abdomen, move all the intestines, get to that kidney with a tumor and remove it. So what have we done? We have manipulated that abdominal stuff in there a lot. And many a times, these children develop paralytic ileus, which means the intestines stop squeezing and moving. And it causes really severe colicky abdominal pain. And then because stuff isn't going down, you're going to be vomiting. And because stuff's not going down, you're getting abdominal distension. And it's all because of all that movement to the surgery where we needed to do it. Pyloric stenosis. This is your young children up to about 3 months. These children are eating and they're happy and they're healthy. There's not a problem with them. Well, the milk can't get to the small intestines because that sphincter, called the pyloric sphincter, is thickened and it's muscular and milk can't go down. So what happens? Well, these children will eat, be really happy, and all of a sudden they will vomit. And you can literally put a garbage can 10 feet away, point the child to it, this infant, and it will projectile that far. When I tell you projectile, it is impressive, okay? Also, know if you have a child infant coming in complaint of vomiting, these young infants, ask, is it just a dribble or is it across the room? Because you have GERD, which we're coming to, and we have pyloric stenosis. How do we treat pyloric stenosis? Make them NPO and give them fluid because they've lost all the milk, right? Get them ready for surgery, and they do really well. Intussusception. Have a child come in. The intestines have come in. You've done the ultrasound. It's confirmed it. What do we need to do? Well, these children, all the swelling is going on here, and the swelling is getting more and more and more. And what they say is NPO because we need to do surgery. This one's going to have it cut out, which they call a colectomy. And so you want this child nice and hydrated, all right? So give them IV fluids. This child is going to be almost to the point of peritonitis if we let it go even further. GERD. Well, GERD depends on the age of the child. We know infants, a little bit of rice cereal in the formula, breast milk, will help keep that food down. But as you get older, what would you eat? Well, it's not going to be pizza. It's not going to be tacos. It's not going to be chocolate. What would be an easy thing? A plain cookie, a piece of bread, right? Be careful with spicy food. So anything not spicy would be a better choice. Now, sometimes we have children and we don't know until they start with the signs. They're all of a sudden now we're seeing their skin turning pale and yellow. Their sclera, you can see the yellow. Their urine turns tea colored. And the stools that are coming out have no bile in them. So they're very pale. This child has biliary atresia, which means the liver is doing nothing for digestion. So this child needs to go to surgery. NPO, go to surgery, get them ready. So neuro, well, sometimes you'll hear very simple things like you have ringing in the ear, you know, these especially school age children, they're always having earbuds in, like me, teaching, or you having your phone in your ear, and now this child's complaining of ringing in the ears. So you're the school nurse, and they come in and complain, my ear or something is ringing. Be the first thing that you would do. Well, again, look at the physical first. Just like the diaper rash, check the ear force first. Do an otoscopic examination. I've actually seen roaches in ears, ants in ears. Crayons is a big one. Little tiny beads. I've seen all of these things in little kids and older kids' ears. Remember meningitis? After we get them on some good droplet precaution, remember that's your priority precaution is always first to protect you and everybody else. And remember, you're going to do a lumbar puncture. Is it viral? Is it bacterial? They both look the same. Remember with seizure, all of those things is all about safety. You're not putting nothing in their mouth. Remember, that is something that on the last exam, some people had the question, and there was a bite block there. Well, no, there's going to be no bite block with seizures. You're going to turn them on their side. You're going to have suction there, only to suction the area if they vomit, not in their mouth. Get all the toys out of there, a bed or wherever they are, bed flat, and call for some help. And if we need to start an IV, they might need some IV medications. Febrile seizures are very scary. 6 months to 6 years old is usually those febrile seizures that we see. It's not uncommon. A parent asks, and they do have these tonic-clonic, and they are scary. The parents are asking, so the kid have epilepsy? Well, one seizure does not mean they have epilepsy. That's the first thing. And the other thing with febrile seizures that you know now that they do have a fever, that they tend to grow out of them. And these would be what you would tell a parent. You would have to have more than one seizure a day for it to be considered epilepsy. And because the child had a fever, we usually see them growing out of them by around age 6, most children. Myelomeningocele. Remember, that is the meninges, that's the spinal column, and the nerves pulled up from the bottoms into the sac. So we have numbness and nerve damage, from like the midwaist down. So what is our concern? It's all about constipation and urine. Big, big thing. Sometimes these children are going to need lifelong catheterizations every 4 hours. And we always, always, always put these children on latex allergies. I mean, I really don't think we need to anymore because we don't really use latex. But remember, latex is that they can go in anaphylaxis. I'm latex allergy because of the latex and the way it came out in the early 80s. And they were scared, and HIV, and everybody wears latex. It was what you needed to wear. And I worked in an NICU. And you scrub your arms every time you walked in and out of the unit. And then you would put on latex gloves. And then you put your hands with these gloves and these moist 110-degree isolates, taking care of these tiny little preemies. And the latex burnt in my skin, and I developed latex allergy. Talk about try to blow up a balloon. My lips will get big and I'll have beautiful big lips for the day, but it can go to the point of anaphylaxis. And that's the concern and what we're trying to prevent. Duchenne muscular dystrophy. Remember, this is X-linked. This is from mommy. We usually see this about age 3. How do we diagnose it? Well, it's all about muscles not working, muscular dystrophy. Muscles not doing what it should. They just are not working as effectively. They do an EMG, electromyogram. And what they do is take either needles or little skin tabs, and they put an electrical shock in it, and they watch the muscle spasm. And they look at the time it took and the strength of the contraction when they put that shock. Well, they do it all over the body. You have just run a 30-mile marathon. All your muscles are going to hurt and ache. Okay. So when these children come back, prepare them, or even already give them some Tylenol before they go down to this test, because they're going to come back aching. And please tell that parent and the child it's not going to be there forever. It's just he just ran a marathon. Okay. Eye injuries, remember, you patch both eyes. Anything in there, leave it there and get them to a ophthalmologist or into an emergency room. Nystagmus, remember the eye exam. We're looking at it at 6 cardinal positions of gaze. That's one of your foundations or your health assessments, right? Hydrocephalus, fluid in the brain. How would you know it's happening? That's why we do head circumferences on early children, and it's the quicker we can get it, the quicker we can help. Now, let's say you were that infant, hydrocephalus, and you have a VP shunt. Remember, you're growing. That, shunt is only so long. It goes behind the ear, in front of the belly, the chest, into the abdomen. There is a big round thing here. We don't touch it. It is like a pump. Do not touch it ever. That's only the neurosurgeon, if they ever do touch it, okay? So why and how would you know that one of these shunts have come apart? Well, the fluid in the brain can't get to the peritoneal cavity. So the fluid is building up. What do you see with hydrocephalus, any brain injury? Increase in fluid, vomiting, headache. Key, vomiting, headache. Now, they did the surgery. They come back up. The next day, you come back in and say, oh, you had your surgery. How's everything? How do you know it worked? They don't have a headache and they're not vomiting. It is as simple as that. Endocrine. One of the things we do every single visit, whether ER, urgent care, doctor office, doesn't matter. We do a height and weight when they walk in the door. We need that for medications, but we also need that to make sure that child is growing the way they should. Is it a thyroid problem? Is it a pituitary problem, right? How do you detect and evaluate hyperpituitarism? Are they too tall? Hyperpituitarism. Are they too short? Hypopituitarism, and the weight goes along with it. That's why we do that all the time. Remember, the parathyroid has nothing to do with the thyroid gland. The parathyroid regulates calcium. Calcium regulates muscle contractions and weaknesses. So if it's hypo, not enough, muscles are weak. Hyperparathyroidism, they're just in spasm, they're tight, okay? Diabetic ketoacidosis. Now, it is asked young children, can they have an insulin pump? Well, as long as they know how to check blood sugars, they know how to run the pump, know how to give boluses, yes, they can. I've seen some books say 5 years old. I think it's a little too young, but there are 5-year-olds that are more than capable, or older children. Again, it is a great choice because they don't have to stick themselves with, insulin coverages, et cetera, all day long. They are getting a slow, continuous infusion of insulin, and that is preferred. One stick, and they could leave it in there for like a week. It's great. So remember, with diabetes, we want kids to be normal. But remember, if they're out there burning calories like crazy, running around, playing football, whatever, remember they need snacks. A child who has like 180 blood sugar going out into playing sports, you would not cover that child, or a 200, because they're going to be burning calories. So making sure that they have little snacks and they have sugar for rescue there, absolutely. And of course, keeping them hydrated. Remember, diabetes, to rotate the injections. Hypoglycemia, it's not enough blood sugar. This is where the body says, oh, I don't feel too good. You have a headache, you're nauseous, sweaty, and you're shaky. One of the things that they see with an infant, the thyroid hormones, remember, there is this relationship. TSH is high, T4 is low. T4 is high, TSH is low. Remember that there's those things when we look at for thyroid and trying to diagnose them. What if you see an adolescent with a really high BMI? Let's say they are urinating a lot. I mean, what would you think it could be? Well, you always suspect it's diabetes, right? So yeah, what are you going to check? Hemoglobin A1C. They're urinating a lot. Well, if they're heavy or not, doesn't matter. Check for urinary tract infection. They're urinating a lot, we're going to be checking electrolytes too. We're worried about potassium. Okay? Common kid disease, impetigo. This is a really bad staph infection. My little Christian had it. My daughter thought he had itched a little mosquito bite too much, and it kept getting oozier and juicier. And then she brought him over to me to watch for a couple days. And I said, no, honey, this is impetigo. And the big thing is don't pop those fluids, leave them. It is oral antibiotics, usually that ceftriaxone, if it's the Keflex. I can't remember the generic name. Keflex. Also, that really, really good Bactroban, that antibiotic ointment that's only prescription, not Neosporin. It's a mupirocin, Bactroban. And you put them on together and it goes away. And hand washing. Conjunctivitis is a big thing. Dirty hands in the face. We know it's ooey, gooey, juicy. Remember, if these children are going to get an ointment, even adults, number one, warm washcloth, water, from the inside out, one the other, clean them, and then put the ointment in, warn them they're going to see blurry until that melts into their eye. I can't imagine, oh my God, I can't see, and children will react and have a moment. So warn them. Remember about ticks. Ticks causes a lot of problems. They've had a tick, and now they're with a fever. What do? You're going to get to the doctor. We're going to be checking the whole body for them, and we're going to be checking to see if they have Lyme disease, right? Tick, Lyme disease. Remember tetanus, where you step on a nail or you step on something, you got an open wound in your foot. The first thing to do is clean it with soap and water and put an antibiotic ointment on it. And then we're going to be checking immunization status. And today, tetanus shots are every 10 years. More diseases, chickenpox. So when are we contagious? 2 days prior to the onset of the rash. And then remember, they cannot go to the school until all the lesions are crusted, and then they can go. Head lice, what do? Well, if you suspect it, check the follicles, right? And then there is those shampoos and a little fine tooth comb and getting all the eggs and all the everything out of there. My daughter's hair was about this thick. She had it down to her butt, and she got it 3 times on me. I was like, I'm tired of washing blankets and pillows and bed linens and her hair. And yes, it is quite cumbersome, but we got rid of them. Otitis media. Remember, children that are breastfed will have a decreased chance of getting otitis media. One of the big things with otitis media is keeping cigarette smoke away from them. Cigarette smoke in a small child causes ear infections. Remember ADHD, this child, there's all things, they're all over, they cannot finish tasks, okay? You need to get them organized. Yes, stimulant meds do work good. Some parents choose them, some don't. It's whatever they want to do. Having organizational charts. They know what they need to do, when they need to do it. Your day is to bring the dirty laundry down. Your day is to take the garbage out, whatever it is. And then keep it the same. It's almost like the autistic child. They like routine and they're comfortable with that. And then one place for homework. So they can't be playing toys and homework and don't know what to do. One place for homework, other places for toys. And we talked about the nosebleed. Infectious diseases. So remember, infection control is always a big thing. When you talk about safety, you talk about infection control. These are things you're always going to see on the HESI, and we're going to see them put there in certain ways. So what am I going to see? Low neutrophil count. Neutrophils are white blood cells. Any child, no matter what, with an elevated neutrophil count that has a fever, this is your priority patient because there is no immune system. They will go into septic shock quickly. It could be an ALL patient, or it could be a post-op patient, or it could be just a medical patient, doesn't matter. Low neutrophil count and a fever, you're in trouble. This child's going to go into septic shock. Infection control at the hospital. Remember, it's all about washing hands. Also about teaching, about using the equipment, making sure parents realize that, you can't just walk around with your kid outside in the hall who's on respiratory isolation. I can't even tell you how many times I've seen that and then have to go back to the room and then explain why. And they're like, oh, gee, I didn't understand. I didn't mean to. No parent wants to hurt another child. Immunosuppressed children, remember anything immunosuppressed. I've mentioned this several times, several different ways. Any immunosuppressed child with a fever, low neutrophil count, get treatment now. It is not giving antipyretics. No, getting somebody in there now. They need to get an IV, they need to get antibiotics, and most likely they'll be moved more into a private room and a higher level bed as a step down or an ICU. That's how sick they are. Remember with immunizations, sometimes you get 4 or 5 at a time. They hurt, they get warm. So right after it's done, move their knees up and down. That helps move in all the medicine. Cool packs are great, and that's called pedaling this part. And then Tylenol, Motrin, acetaminophen, ibuprofen, whatever you want to call it, for discomfort. Remember, no Motrin, ibuprofen until a baby is 6 months old. The MMR is at 12 months, second at 4 to 6 months. And we know rheumatic fever is by that strep throat. And as I said, that really weird movements, which is sometimes what brought them in for treatment, that chorea, it will disappear with treating that infection. Acid base. One HESI had 4 acid base questions. So remember these, very important. Hyperventilating respiratory alkalosis and Kussmaul's respiratory alkalosis. It's more like, right? Now, diarrhea, all of those digestive enzymes are all alkaline. So you're getting rid of alkaline. So what is left? Acid. So it's metabolic acidosis. What does the stomach have in it? Stomach acid. So you're vomiting. What do you have left? The acid is gone. You're left with alkalosis. I hope that helps you. And I put pictures there if you want to see some more. So again, like I tell all of my students, remember, read the question. And when you think you have the answer, go back and read the question to make sure you're answering what the question is asking for. This is the most common mistake students make. They're going to say what would tell you that this parent doesn't know what they're doing, that needs further teaching. Any questions? Sure.
So the only question that I have is back on the GERD. I came across 2 different questions about adding the rice cereal into the diet or whatever, but it never specified an age. And I thought there was still an age.
Right. Okay. Very, very good question. I appreciate that one. Okay. Rice cereal is not digested by the body till 5 or 6 months. But if you're spitting up all your milk, you're going to take the rice cereal, 1 teaspoon in every ounce of formula. It holds the food down. Yes, the rice cereal will come out in the stool because you can't digest it yet.
Thank you.
That's the rice cereal. Makes sense now, doesn't it? Okay, good. Anybody else?
Will this review be sent out to us?
Listen, it'll be up. Does everybody know my YouTube channel?
Okay.
Before even your professor will have it up, it's going to be on Professor Bogart, Pediatric Nursing, and you'll see the HESI Q&A, and it will be there. And give me about 30 minutes. It'll be there.
Okay.
How does
Thank
that
you.
sound?
So
I wish
Professor,
you
I have a
all good
question.
luck.
I have a question.
Thank you.
I have a question.
Sure.